Hello, we're going to teach you a system that we've developed to try and help you evaluate echo images and clips, certainly in an emergency situation where time is critical, but managing to get the information from the clips in a shorter amount of time by using a structured DEFG approach. Okay, so for instance, you had a patient who was about to die on you in the emergency department, and you have a short amount of time to try and find out what's going on and treat them appropriately. Now, if you were to get a view such as this, which is a parasternal long axis view, looking at it, it seems to be grossly abnormal, and in pressure situations, this can be quite overwhelming. So what we want to do is to teach you a system where you can break things down into bite-sized digestible chunks to try and ensure you yield the maximum amount of information from each echo clip. So D stands for D for dimensions and structure. Now this is really about looking at the main architecture, recognizing the view and seeing if all areas conform to sort of normal expected dimensions and ratios. So when you're looking at views where the right heart is adjacent to the left heart, so the views that you've learnt on in the podcast, such as the subcostal four chamber and the apical four chamber views, you can see them both side by side. And we know that certainly around the level of the mitral and tricuspid valves, the right side should not be more than 2/3 the diameter of the left. So we're not talking about minute changes, we're talking about quite obvious gross abnormalities of this particular ratio. So for instance, from the podcast, remember we said that if the right side was grossly dilated, it may be an indicator of a massive pulmonary embolus, and this is something that you might want to treat in an emergency situation. Also, being able to look at the normal chamber sizes is quite helpful. And again, it's not about being pedantic and extremely accurate. It's about just getting an overall feel for do they look big or small. And when you comment on these things, we don't expect you to have the answers of why they're big or small, but it's reasonable to expect you to just say, well, they don't look normal, and they are too small or too large, etc. So it's about the findings as opposed to the reasons why they are that way. So for instance, on the parasternal long axis, remember we can see the aortic root, the left atrium and the left ventricle. And we said that the left atrium and aortic root should be less than 4 centimetres. Now, without using a ruler or calipers on the ultrasound machine, you can just look at the side scale, and most of the side scales will be in centimetre markings, and that can give you a good rule of thumb. So we're looking for things where there's significant deviation from this normal. Also, looking at the internal diameter of the left ventricle, now this can be on the parasternal long axis, but it can also be on other views where the left ventricle is clearly seen, because remember in cross-section the left ventricle is fairly round. So, is the internal diameter at its maximum, i.e. at the end of diastole, less than 6 centimetres? Also look at the wall thickness of the left ventricle. Now we know that the left ventricle wall should be about 1 centimetre thickness in the relaxed state, i.e. in diastole. Now again, there is a range between about 9 and 12 millimetres, but what we're really looking for is, is it significantly thickened or is it significantly thin compared to what you would expect? So these for dimensions and structures. So check your view and go through and just make a general assessment of the dimensions and ratios. So E is for effort. So really this is a heart pumping well? So when we're looking at this, we just want to see, is it pumping well? And we know that there's some criteria that we've covered in our podcast that may help us. So we know that the left ventricle, for instance, it narrows the internal diameter because it's radially contracting, and it narrows by about 30% during systole. So we could look at certain areas of the left ventricle, certainly at the tip of the mitral valves, which is a good area to look and see, is this actually happening? Also, we know that a good marker is looking at for thickening in the left ventricular walls. We know from the podcast that the walls are supplied by three different blood supply routes, and it can give us an idea if they're occluded, whether or not they thicken or not. So thickening of left ventricle walls by 30 to 40% during systole is what we can look for. Sometimes these can be subtle, but just having a look for 10 seconds and seeing whether or not you think there's any thickening there is probably all that's needed at your stage. The other thing is that we know that good blood flow through the heart results in the mitral valve anterior leaflet being flipped up and almost touching the septal wall. So is this happening or not? Now, with regards to evaluating for right heart function, now in certain cases such as right coronary artery occlusion, which affect the inferior and possibly the right ventricular walls, there may be a problem with right ventricular function. Now, this is probably a bit too advanced for your stage, but simple things such as on views such as the subcostal forechamber, the apical forechamber, we know that there is a longitudinal contraction, i.e. where the tricuspid valve is going to be contracted towards the apex during systole. So it moves backwards and forwards. Is that actually happening? So is the area around the tricuspid valve actually moving towards the apex during systole? So really, ease for effort, is the heart pumping well? Okay, moving on to F for fluid around and adjacent to the heart. Is there fluid around the heart in the pericardial space, or is there fluid adjacent to the heart? So this may not be in the pericardial space, but for instance on subcostal forechamber views, sometimes you can see fluid in the peritoneal space, and on things like the parasternal long axis, below and to the left of the descending thoracic aorta, you may actually see fluid in the left pleural space. So F is for fluid. So G is for gradients. So gradients really is looking at the valves and for any abnormal flow. And on this we can use colour flow Doppler as well. So a good way to start for G is to start off and saying, what valves can I see on this particular view? Do they look normal? I.e. is the mitral valve grossly thickened? We know that the leaflet should be less than 4 millimeters. The smaller cusp of the aortic valve should be less than 1 millimeter in normal state. So just looking and saying, do they look thickened? Or do they look normal? The other thing is, are they moving normally? So we know that the valves often flip up and close during the cardiac cycle. Is there a restriction to movement, or is there abnormal movement, say a paradoxical movement that you've seen? Again, we're looking for quite grossly abnormal things. And lastly, there may be some application of colour Doppler on some of the clips you see. And so, is this showing abnormal flow, such as regurgitation across the valve? Moving away from valves, there may be also abnormal flow across things such as holes in the septal wall. This may be ventricular, or it may be interatrial septal wall where there's colour flow applied, which clearly shows a jet of flow that shouldn't be there across a septal wall. So, G's for gradients. So let's move back to this image. Can you see that this is a parasternal long axis? So, for instance, imagine yourself in an emergency department. It's late at night, the department's very busy, and this patient's being radio called in with deteriorating blood pressure and looks like they're in extremis and about to die. You've been asked to try and save them. So you performed a bedside echo, and this is a view that you've got on the parasternal lung axis. Now the pressure's on to really see, can you yield information from this that might help you in your resuscitation. So looking at it, it looks grossly abnormal. It doesn't look like the normal views that you've seen so far of the parasternal lung axis. So let's use our system. So D for dimensions. Now we know from the scale on the right side that the small dots represent 1 centimetre markings. So let's have a look at the aortic root, and it's certainly less than 4 centimetres. If you can't find the aortic root, just remember, look below the right ventricular outflow tract at the top. Then below the aortic root, there's a left atrium. Now, it would be reasonable to comment on whether this is significantly small too. So we know that it's certainly less than 4 centimetres, just estimating its appearances against the scale on the right, but looks like it almost occludes during the diastole phase. So it's certainly smaller than we would expect and collapsing. Now looking at the left ventricle, now this looks really strange, and it looks really strange because the internal diameter is actually quite small and narrow, and certainly less than the 6 centimetres we would say would be the maximum we would expect in diastole. So looking at the left ventricle wall as well, we know this should be about a centimetre. So trying to look at the part you can see in a relaxed phase can be challenging, but there may be slight thickening seen here, but at least you can make an assessment of the normal non-thickened state and see whether or not you think it's normal. So I think this is probably slightly thickened. Okay, so D for dimensions, well, that's been quite useful so far. We've made an assessment that we've got a narrowed and small left atrium and also left ventricle. In fact, the left ventricle walls look like they're almost touching each other in systole. The next thing we're going to do is now move on to E for effort. So really, is our heart pumping well? Well, let's have a look at the for thickening of the left ventricle. This is certainly thickening, isn't it? You can see that during the cardiac cycle, there seems to be thickening, and from what I can see, it looks like most of the left ventricle wall is thickening during systole. Also, is it radially contracting? So it looks like the walls, as we said earlier, are almost touching themselves at the end of systole. So there does seem to be radial contraction by more than 30%. So although we've commented on small chamber sizes in D, certainly the effort looks like there is reasonable effort to the left ventricle seen on this view. We wouldn't be able to comment on the right ventricle function on this view. Okay, so we've covered D for dimensions and structure, E for effort, and now we're moving to F for fluid. So if you can see above and to the left of the descending thoracic aorta, which is a round stroke oval black area at the bottom, there is evidence of pericardial fluid. So there's also a suspicion below and to the left of the descending thoracic aorta that there's possibly some pleural fluid also. So there's fluid above and below the pericardial line. So from a fluid evaluation point of view, I would say that there is probably a pericardial and a left pleural effusion. And if we were to look at the maximum diameter we can see of the pericardial fluid, certainly goes up to about 2 centimetres in thickness. Although arbitrary, it certainly gives you an idea that this is not a tiny pericardial effusion. Okay, so we know we've got some fluid. Let's move on now to G for gradients. So what valves can we see? Well, we can see the mitral valve, and when we were looking earlier, we can see it's actually flipping up and touching the septal wall. And we know that the mitral valve leaflet tip should be less than 4 millimeters. So I would say that there's probably it's probably just within normal at the max, whether it's 3 to 4 millimeter thickened at the end. But certainly looks like it's opening and closing, and it looks fairly normal, although there's a slight thickening to the tip, which is probably just within normal limits. Okay, can we see the aortic valve above and to the right? Well, it's not clearly seen because this clip keeps wandering off the axis of the aortic valve. So I think it's reasonable to say that you haven't fully been able to see the aortic valve in this view and to make a assessment of whether or not it is thickened or whether it's moving normally. On this view, there's no colour Doppler applied, so we wouldn't be able to assess whether or not there's any regurgitation or stenosis, and also we wouldn't be able to look at any intraventricular or intra-atrial septal problems. This is probably not the right view to use for that type of evaluation. Okay, but at least we've managed to look at the valves that we can see and see that they're essentially, certainly the mitral valve is working normally. Okay, so we think that by using a system such as a DEFG system, it means that in a pressured situation, you can yield the maximum amount of information out of echo clips and images in a shorter amount of time. Sometimes when you're faced with an overwhelming problem, it's easier to break it down into bite-sized chunks, and that's the philosophy behind this. So remember, D for dimensions and structure, E for effort, i.e. is the heart pumping well, F for fluid, is there any fluid around or adjacent to the heart, and G for gradients, what valves can you see? Do they look normal? Are they opening and closing normally? Or are they moving normally or limited movement? And also if there's colour flow Doppler applied, is there any abnormal jets that are seen to indicate things such as regurgitation? And also this may also be helpful for looking at septal or other abnormal flow areas. So remember, DEFG. D for dimensions and structure, E for effort, is the heart pumping well, F for fluid adjacent or around the heart, and G for gradients, looking at the valves and abnormal flow. Okay, well, good luck with your test, and hopefully the DEFG will help you identify abnormalities earlier.